Okay, good afternoon. I'm Karel Van Keer from the University Hospitals Leuven. I'm a resident in ophthalmology, and I also do a PhD in the supervision of Evelien van der Walle, Ingeborg Stalmans, and Luis Pinto. My presentation starts off where the presentation of Professor Stefansson ended, retinal oximetry in non-ocular diseases. The idea to use the retinal fundus, retinal vasculature, as a parameter for systemic diseases is not new. In fact, immediately after the invention of the ophthalmoscope in 1851, it was noted that patients with severe systemic diseases also had severe retinal complications. This, for example, is a fundus of a 22-year-old diabetic patient in 1869. And so as our devices evolved and as the computational power became freely available, it became possible to detect ever more subtle changes in the diameter, in the branching pattern, etc. of the retinal vasculature. And now we are at the point where we can even predict some systemic diseases before major complications have occurred. So with retinal oximetry, we might take this to a new level by looking not only at structure, but also at the function of the retinal circulation. And today I will present two preliminary pilot studies we performed on the use of retinal oximetry as a cerebro. Which one is point? The top one. As a cerebro and cardiovascular parameter. Okay, so the first study to find a correlation between retinal and cerebral oxygen saturation. And as pointed out before, there are some similarities between the retinal and cerebral circulation, and it is known for quite some time that the structural features of the retinal circulation may change, and that these changes may occur in synchrony with changes in the cerebral circulation. Now, for the first time, the paper published recently shows that also the retinal metabolic features may change in patients with central nervous system diseases. So we thought it would make sense to investigate whether retinal and cerebral oxygen saturation were correlated. And to do this, we used a device called a transcranial cerebral oximeter, and this uses transmission spectroscopy with near-infrared lights because they can penetrate through the skull. And this device is clinically used quite often during surgery to monitor cerebral oxygenation during cardiac and carotid surgery, but it's also been investigated to predict neurological outcome after cardiac resuscitation, and also as a surrogate for cardiac outputs in pediatric patients. However, transcranial oximetry has several drawbacks, and the first is that it does not only measure the cerebral saturation, but is also contaminated by the superficial layers, because these waves have to first to traverse the skin, the skull, the dura, and only then they encounter the cerebral cortex, and then also they come back. And so this might be a problem in cases when the peripheral saturation is in vasoconstriction, such as during hypovolemia or when in therapeutic hypothermia. And so this influences the value that we get. And another major limitation is that we only get one value, and that is a composite of an arterial and venous fraction. And so, for example, if we have an arterial saturation of 98%, a venous saturation of 65%, we get one single value, and for the device we used, that calibration, the relative contribution is said to be 30% arterial, 70% venous. But it's not that this relative contribution is very variable in between patients and also in patients, in healthy patients, and probably even more so in critically ill patients. But of course, retinal oximetry is not contaminated by superficial peripheral circulation, and because we can actually see what we are measuring, we can measure arterial and venous saturation separately. So we started a pilot study to provide proof of concept for the use of retinal oximetry in assessing cerebral oxygenation. We chose 22 healthy young volunteers. We dilated them, had them rest for 20 minutes, and then we measured the blood pressure, peripheral pulse saturation, transcranial saturation, and the retinal saturation. And so these are our results. We had to exclude one patient, but for the rest we have a fairly healthy young population. And when we look at the saturations, as we can expect from a homogeneous group with healthy patients all breathing ambient air, there is little variation in the oxygen saturations. Nevertheless, we did find some correlations. We found a positive correlation, it's a weak positive correlation, but there's also a small sample size between the retinal arterial saturation and the transcranial saturation. A positive correlation between the retinal venous saturation and the transcranial saturation. And then another interesting thing that we noted was a negative correlation between the retinal venous diameter and the transcranial saturation. And we believe a possible explanation might be that the retinal venodilation and cerebral venodilation are somehow correlated. And when the cerebral veins dilate, they contribute more to the measure obtained by the transcranial oximeter. So a larger vein would result in a lower transcranial saturation. And more about this relative contribution, which is said to be 30%, 70% in healthy individuals. We tried to calculate what our relative contribution would be, equation, x times the arterial plus 1 minus x the venous retinal saturation. And we find 31% versus 69%, which matches quite closely to the established 30%, 70%. However, if we look at individuals, there is large variation, and that's exactly what is one of the downsides of the transcranial saturation, and the ranges we report here are quite in congruence with what's reported in literature. So here we show the absolute correlation, absolute agreement between the measured transcranial saturation and the expected saturation when we use the 30%, 70% ratio. We have an intra-class correlation of 0.64. So in conclusion, this was a pilot study to investigate correlation between retinal vessel oxygen saturation and cerebral oxygen saturation measured non-invasively. We found that both retinal arterial and retinal venous oxygen saturation are positively correlated with transcranial saturation. The average relative partition matches very closely to the established 30%, 70%, but shows large inter-individual variation. And lastly, we found a negative correlation between retinal venous diameter and transcranial oximetry. Of course, this was a sample size with many limitations. First of all, the small sample size, and also a major limitation is the lack of an exact measurement of the true cerebral saturation. The first study we did, then we moved on to a second pilot study, which is still ongoing, and I will now present the first results. And this is a study on the correlation between saturation and mixed venous oxygen saturation. And so one might ask, why mixed venous oxygen saturation? Well, in critically ill patients, as said before, because of a constriction of the peripheral circulation, it's not always good to use the peripheral saturation as a parameter for systemic condition. And there's also sometimes a problem when there is a non-perfusion of certain tissues, even in the absence of abnormal blood pressure or peripheral pulse saturation. So it's perfectly possible to have a good blood pressure of a relatively good blood pressure, a normal peripheral pulse saturation, and even in this situation have ongoing ischemia. And then what else can we use to monitor these patients? Arterial blood gas values are not that interesting, because if we ventilate patients with 100% oxygen, nearly all patients have very high levels of arterial saturation. The gold standard, of course, is lactate. However, some tissues do not produce much lactate, such as the cerebral cortex does not produce much lactate, even in ischemia. And as being said before, then we only measure the result of ischemia. We do not measure the ischemia itself. And so that's why mixed venous oxygen saturation, it's a saturation inside the arteria pulmonalis. So when blood returns to the right heart and is pumped back into the lungs just before it arrives in the lungs, that's the mixed venous oxygen saturation. There have been some of one publication that I know of investigating the correlation between the retinal arterial saturation and the invasively measured saturation of the femoral artery. They found a positive correlation. And of course, there have also been studies investigating the retinal venous saturation with the mixed venous saturation. This was done by Denninghoff. He investigated the correlation between retinal venous saturation and mixed venous saturation, and also between retinal venous saturation and cardiac output in swines that he let exsanguinate. And then he found that when the swines were exsanguinated, the cardiac output declined, and in parallel the retinal venous saturation declined. And when they were reinfused, when they were resuscitated, the saturation rised again. So we wanted to repeat these experiments in humans, but of course it's difficult to find healthy individuals willingly to let them exsanguinate. So we had to search for another population, and it shows patients on the waiting list for or after heart transplantation, because these patients are very well monitored, and at least once a year they are hospitalized for 2 days and they receive every conceivable cardiovascular test. But then the evening, so they have, during the day we cannot examine them because they are being carried from one department to the next, but in the evening they stay at their room doing nothing, and then we go to them, ask them whether they want to participate in the study. And so now we have already 12 patients. 2 of them have not yet been transplanted. As you see here is a very heterogeneous population. We have patients, the youngest one is 21, the oldest one is 77. The indication for the heart transplantation, we have most of them are for ischemic cardiomyopathy, 4 for dilated cardiomyopathy, and 2 for hypertrophic cardiomyopathy. The time since transplantation ranges from 3 to 27 years, so very heterogeneous population. And these are our results for the saturations, so a little bit higher than we found in healthy individuals. And when we plot the venous saturation on the x-axis versus the mixed venous saturation, there is a problem that has come back a few times today, and that's the variation between the patients, because all of these patients in the red box have a mixed venous saturation that is around 70-75%, which is normal after heart transplantation, yet the retinal venous saturation varies a lot between them. And so we looked at the indication of the heart transplantation, and we saw that for the most part the patients with the higher retinal venous saturation are the ones with the ischemic cardiomyopathy, except for one patient. So these 2, the one here and the one here, are not yet transplanted. This patient in between has received a HeartMate, a ventricular assist device, because he was really not going well. And so except for this patient, all the ischemic cardiomyopathy patients are towards the higher end of the retinal venous saturation. But all these patients that have received a heart transplantation, in fact, are all at risk for microvascular changes, because they take many medication, also cyclosporin, tacrolimus, and that's known to have a very bad influence on the microvasculature. And major problem in these patients is chronic kidney failure. And chronic kidney failure is known to be correlated with the retinal arterial diameter. And an interesting finding we found in our small population so far is a strong negative correlation between the time since heart transplantation, so a parameter for the amount of medication received, and the retinal arterial diameter. So when we looked at AV difference mean of 34.7, we did find a significant correlation between the AV difference and mixed central venous saturation, which is mainly caused by this one outlier, but we only had 2 patients who had not received the heart transplantation. So we hope that when we increase the sample size and have more patients with low saturations, we can confirm this finding. So yes, we should increase our sample size, but the study is still ongoing. But we should also look at longitudinal data for these patients. They come back each and every year, at least each and every year. And so what would be interesting, for example, is this patient that's now here, before he developed this degree of heart failure, was he also here toward the higher end of the retinal venous saturation, and did he drop? And so if we follow these patients when the venous saturation rises, is that may that be a parameter for microvascular disease? And when the venous saturation drops, might that be a parameter for decreasing cardiac function? So these were the results of the first two pilot studies we performed. In conclusion, we think that the ability of retinal oximetry to measure central arterial and venous oxygen saturation separately without contamination of the superficial peripheral circulation, and plus being able to do this non-invasively may be very useful in non-ophthalmological conditions. But of course, exactly in these patients, it would be really interesting to be able to perform this in a portable manner. We've been investigating how to do this. Tomorrow we will hear a lot more about this. We have now a very small hyperspectral snapshot sensor that is C-mountable, and so we're planning to investigate, when we attach this to the rear port of our Topcon, whether the resolution of this sensor would be good enough for some basic oximetry. Thank you.